Hello, this is your brain on drugs, punk rock psychiatrist here, and today we're going to be talking about some of the receptor selective antidepressants. And so, just get my screen pulled up here. So, this is going to be a short episode. I'm just going to kind of go through a brief overview. We went through the MAO inhibitors, we went through the tricyclics, and now we're going to go through the what some people might call the second generation antidepressants. This would be pretty much everything that came after the tricyclics until some of the newer stuff started coming out in the last few years. And those would be medications like Spravato or brexanolone, and some of these newer agents, the ones that don't work on the monoamines. And so I'm just going to do a brief overview of the second generations, what I'm calling receptor selective antidepressants. So if you can see the slides here, I've got a list of all the meds on the left side and a list of all of the conditions that they could potentially treat on the top, and they're abbreviated. And on the next slide, I actually define that, but I'm going to talk through this. So I'm going to go through each of the different disorders that these medications are FDA approved for, and then I'll talk about what medications are FDA approved for that. All right. So first off, we're talking about antidepressants, major depressive disorder. So almost all of the medications on the list are approved for major depressive disorder. And so just to kind of read down through the list, we've got our SSRIs, SNRIs. We've got medications that are SSRIs plus, I guess we could call them. They have a little bit extra function. And then you've got your SARIs and your mirtazapine, which is kind of in a category of its own, and then the NDRIs. So SSRIs, we got fluoxetine, sertraline, paroxetine. We got controlled release paroxetine because it actually has some separate things that it's approved for. Fluvoxamine, citalopram, and escitalopram. And then vilazodone is sort of like an SSRI, but has a little bit of extra function. Vortioxetine is similar in that respect. It's got a little bit of extra function. And then you've got your SARIs, trazodone, nifazodone, and then mirtazapine. And then we've got the SNRIs, venlafaxine, duloxetine, desvenlafaxine, milnacipran, levomilnacipran. And then we've got gepirone, which is the newest medication on this list, is a 5-HT1A partial agonist, and then bupropion, which is a NDRI, norepinephrine dopamine reuptake inhibitor. So, as I said, not every medication on this list is approved for major depressive disorder. Fluvoxamine, Luvox, is actually only approved for OCD. And I think some people kind of mistake it for, well, since it's approved for OCD and nothing else, it must be the best med for OCD. And so I often see patients that are started on Luvox first because, well, it's kind of like clomipramine. Clomipramine isn't approved for depression, it's approved for OCD only. And so it's thought that, these are better. Well, clomipramine probably is maybe a little bit better, but likely not worth the other baggage that goes along with it that we discussed that before. And we're going to talk about OCD when we go through our anxiety stuff. So but I want to go over each of the meds that are in these categories and what they're approved for anyway. So Luvox only approved for OCD, not approved for MDD. And then the other med in the list that's not approved for major depressive disorder or depression is milnacipran. It only has indications for fibromyalgia. Um, it's an SNRI, serotonin norepinephrine reuptake inhibitor. Does that mean it couldn't be used for depression? It may very well be effective, but why would you ever use it if you could choose one of the other 25 medications that did have FDA approval? There's really no reason to go off label on depression in the direction of milnacipran because you've got several other SNRIs to choose from. Now, if you had a patient that had fibromyalgia and depression, this might be something to consider. Okay, we could hit two birds with one stone. It's approved for the fibromyalgia, but it has properties similar to other meds that are approved for depression. Maybe I don't need to give her something or him something for depression as well. Um, I could maybe the milnacipran would cover that. So that would be, that would kind of be my thinking. But I've actually never prescribed milnacipran, but it doesn't have the depression indication. And as I said, I like to stay on FDA approvals, especially for your first go. You're going to want to go for an FDA approved indication medication. If you're treating like I said, but if you're treating something else, then you could consider something that theoretically could work for the thing that's not FDA approved while you're also treating the thing that is FDA approved for. And, if you've tried a couple of FDA approved medications and you think mechanistically this is how this medication works, I think this might be helpful to this patient, even though we don't have the approval. Maybe, and a lot of times, like a tricyclic, for example, it being approved in the 1960s and 1970s, it's off patent. It's not, no one's making any money off these meds anymore. They're not going after approval for a different condition anymore. So could you consider using one for anxiety that wasn't approved for that? No one's going to go through that, perhaps because it's a lot of money to do that study. I would probably still look for a study of some kind. We don't necessarily have to have FDA approval to go off label, but we want to at least have some sort of literature that would point us in that direction. So, um, as the patient becomes more and more resistant to treatment, I become more and more willing to go off label. And in some cases, there's minimal things available to treat. Like PTSD is one that there's just not a lot of treatments out there. So you're going to exhaust the FDA approved treatments pretty quick. And so you could jump off label a lot quicker with something like that if you felt like it made sense too. But when we're talking about depression, we just have so many meds that are approved for depression. We would never go through them all. It would be rare that I would say, let's go off label for depression. But probably have in the past. So that's the depression indication medications. Next would be GAD, generalized anxiety disorder. So there's four meds that have an FDA approval for this: paroxetine, escitalopram, venlafaxine, and duloxetine. Next, SAD, that's social anxiety disorder. There's actually two SADs. We'll get to the other one later. But for social anxiety disorder, we've got sertraline, paroxetine, paroxetine controlled release, escitalopram, and venlafaxine. Next, OCD, obsessive compulsive disorder, we've got fluoxetine, sertraline, paroxetine, and fluvoxamine. Already mentioned that one. Next, panic disorder. So we got fluoxetine, sertraline, paroxetine, and paroxetine controlled release. Next, bulimia nervosa. Fluoxetine is the only med that is approved for bulimia nervosa. Next, PMDD, that's premenstrual dysphoric disorder. What those of you out in the lay public would call PMS, premenstrual syndrome. There's actually three medications that are FDA approved for this: fluoxetine, sertraline, and paroxetine controlled release. And there's actually paroxetine's got some funny extra labeled stuff. And when we talk about paroxetine, we'll talk about those other branded products that kind of have some niche uses that are not really used for those things. Sometimes these drug companies, they're trying, they're trying to find ways of selling their product. And so, if you can be the only medication that's approved for bulimia nervosa, then you can make some money, right? So fluoxetine, what you're going to notice is paroxetine and fluoxetine are approved for a ton of stuff. And they're also like the two oldest medications on this list. So they've been around a long time, patents expire. companies are still trying to make money, and they're like, "Oh, let's do a study on bulimia nervosa. Oh, we found that, it's statistically significant. Now I can say fluoxetine, the only treatment for bulimia nervosa." Now, does that necessarily mean that another medication might not also be helpful? Or might it mean that, fluoxetine might not be all that helpful either, but it just was statistically significant, right? So, y in some respects, you have to take some of these FDA approvals with a grain of salt, but it is a big deal to be FDA approved for something. Now, data can be manipulated, statistics can be chosen to find the ones that give you the results you want. Um, you have to read the studies. You gotta read the studies, you've gotta look through the statistics, you've gotta go through all this stuff if you really wanna know the truth, and to be honest, it's still often buried, and so, while I say, throughout the podcast, what you're gonna hear from me is like, "Okay, yeah, this is FDA approved for this, but I would have no problem using something else." And in some cases I would, and in some cases I wouldn't, and it has to do with what other data is out there, what's the risk, is this a very low risk medication, is this a very cheap medication? Hey, if it's really cheap and it's really low risk and you've tried some other stuff, then yeah, go and you've got some mechanistic sense that you can justify in your write up, then yeah, try the off label, see what happens. It could work out for you. But if you've got something that's higher risk and it's off label, then you're taking on, a little more risk there. And I wouldn't say that you can't do it. I would say that you just are going to have to be able to back it up more. You're going to have to be able to say, well, I discussed this with the patient and we went over this and we've already tried these other things. And so you've got to make a little bit more case for it. Um, but, we go off label as physicians, we go off label all the time. I would, like I said, try to stay on label, but I don't really have a problem going off label. I do it often. You'll find that out. We'll talk about that. But you've got to have a good reason. Okay, so fluoxetine didn't work for bulimia nervosa, and you want to try something else, and it mechanistically has a similar, you're not gonna have a huge problem getting that approved, or you're not gonna get a lot. Your risk of getting in trouble doing something like that's gonna be exceedingly low. So, the next one that I want to talk about is for the condition of bipolar depression, and this is for use with a mood stabilizer. Fluoxetine is actually the only antidepressant on this list. I think, when we did the TCAs, it was doxepin that also had the FDA approval. But like I said, I'm not a huge fan of this. Not a huge fan of using antidepressants in a patient who has a bipolar spectrum disorder. But we will go into more detail on that when we talk about bipolar disorder. But since we're on the topic of antidepressants and fluoxetine is one, it is the only one of the list that I went over just now that has approval for the depression in bipolar disorder, but you also have to have a mood stabilizer on board on the patient. You can't just treat them with only the fluoxetine, okay? Because the risk of flipping them to mania is there. Next, PTSD, post traumatic stress disorder. So we've just got sertraline and paroxetine, and I'm not a big fan of paroxetine. I don't think most people are. We go off label on PTSD all the time. And do I reach for sertraline first? Often not. I'll often go escitalopram, and like I said, there's not a huge problem with doing that, especially in the military system that I used to practice in. It's way easier to go off label. In the civilian sector, you may have to go with the sertraline first and then try something else. I mean, paroxetine, there's reasons not to use paroxetine that you could justify to skip that one, but those are the only two that actually have FDA approval for PTSD. So next is vasomotor symptoms of menopause. I'm not sure if that S is symptoms, but we will talk about this in depth later. I'm going to have an entire podcast on this. So, vasomotors, these are symptoms or syndromes of menopause. So, this is, hot flashes essentially. And that's just the medical term for hot flashes. Paroxetine is the only med on this list that has an approval. There's actually a couple more meds that are approved for this. Um, but that just for your own sake of knowledge, paroxetine is the one with the FDA approval for it, but we will go into more depth because I'm gonna have a lot of information on menopause and treatments and what to do for that a little later. So next is the other SAD, so not social anxiety disorder, but this one is seasonal affective disorder. So that's that's when you have the depression, but typically it's in the cloudier months, the colder, rainier time of the year. People get depressed. Um, there is a summer type. Sometimes I think I am. I'm not a big fan of hot weather. I actually am much happier when it is cold and wet and dark. I'm a crazy vampire like that, I guess. But for most people, they don't like that type of weather. And sometimes when that time of the year rolls around, they will get more depression. And sometimes it could be just from cloudiness. So that's what seasonal affective disorder is. It's basically depression based on season, and pretty much winter is what we're talking about. Um, and bupropion is the only medication on this list that has FDA approval for that very specific condition. But would it be very easy to say that somebody just has major depressive disorder? Because someone that has seasonal affective disorder probably meets criteria for major depressive disorder, and then you've got all those other meds. um, this is the thing about mental health. It's not an exact science. So many people like really try to fit these things into these boxes and these categories, but all of these are syndromes, right? And what's a syndrome? A syndrome is just a cluster of symptoms that we describe with a term that we don't actually have any physical reason. Like if we could say, oh, if you have this chemical that's at this level or lower, then that's major depressive disorder. We don't have those kinds of tests, right? It's very complicated. I've talked about this in previous episodes, and we'll talk about it over and over again. These are all syndromes. All of this, every single psychiatric diagnosis is a syndrome. I can't think of any offhand right now that are not. It. I think when a psychiatric disorder leaves the space of syndrome and moves into the space of, oh, we have very clear criteria, and we have like we can look in the brain, and we can look at an MRI, and we could see this, or we can measure a lab. It becomes neurology, right? I mean, if you look at any neurologist or any psychiatrist, we're all part of the board of psychiatry and neurology, right? ABPN. I'm board certified in the American Board of Psychiatry and Neurology. So in the United States, that's how we group it. I'm not sure, if there's listeners in other countries, if you guys group it together, but psychiatry and neurology used to kind of be the same thing, and they've kind of, floated apart. And I think of neurology as like, this is the thing that we have like a lot more evidence of, that we know more clearly what it is. And the things that are still more kind of nebulous and syndromey, those fall into the psychiatry category. And this is one thing that makes psychiatry so difficult, is because we don't have the brain scans, we don't have the lab tests, we don't have even the physical exam findings where we can say clearly you have this. We have this book called the Diagnostic, Statistical Manual, DSM, and we're on part 5, I think. Is it TR or R? It was 4 TR. I think it might be 5 TR. This is the manual we're on now. And so it's like you could have a disorder in the 5, but not in the 4, but in the 2, but not the 3. And it's like it's all kind of just like sort of made up, but made up at our best guess based on evidence. Um, but that's why, yeah, I could say you have MDD, or I could say you have SAD. It could be. It's hard to say. are these even really different disorders? Are they even disorders at all? Like, it's really difficult. But we do our best. We try to say, okay, I think that your symptoms are kind of fitting this cluster, and I think a medication that hits these type of receptors in your brain might be the best one to go with. Let's give it a try. And I mean, I know that's not very satisfying, and I think sometimes patients have a negative reaction to that. Because well, I think sometimes that people want more of an answer, and why wouldn't you? And then I think sometimes doctors, they put forward that they do have more clear of an answer. Oh, you definitely have this. And it's like, well, we can't really test for it. It's really your professional opinion, and somebody else might have a different professional opinion. And I mean, that has to do with all medical issues, but there is no specialty in medicine where it is more opinion based than psychiatry. And that's part of why I wanted to do this podcast, is because, you know, I don't like that people push it and make it sound like, oh, we have more evidence than we actually do. And I also don't like that, I know it's very unsatisfying that we don't have more evidence, but I want people to know, hey, we don't have that great of evidence. We do our best. You've come to me. You're struggling, right? You wouldn't be coming to see me if you weren't struggling. So you're here. I'm going to ask you a lot of questions. They may be questions that you've answered 10 times before, and that's frustrating, but like, I'm trying to put together a picture of what I think is going on. I'm not looking at the DSM, checking off criteria boxes, and then doing some sort of AI formula algorithm, and it spits out what you have, right? Because it's very complicated. And because even if you have depression, right? Why do you have depression? It could be an organic reason, like a neurological reason. There could be like a neurological reason. It could be a medication you're taking. It could be a medical issue. It could be a substance that you're using. It could be a life events that are happening. It could be some sort of organic thing in your brain that we don't quite understand. And it could be that, and there could be like 10 different types of that, right? And so we have to have some sort of basis to go off of, and that's why we create these definitions for these disorders. But I mean, I use it, but I also don't feel tied down to it. Okay, so that's we're gonna go. You're gonna feel this is gonna be the theme throughout the podcast. Is this is not a hard science. We're doing our best, and and the thing is, I could have a different opinion than somebody else, and I could have a different opinion a month from now than I had today, because your symptoms could look different, right? And they could change and evolve. And I'm just trying to find a med that works best for you, or find a medical problem that I think could be causing it, or take a med off that I think could be causing the problem, or say, hey, you should go get therapy, or make some life changes, or change your diet or exercise. You know, you're struggling, you're feeling down, you're depressed, you're not happy, you're having these symptoms. What can we do? Right? So there's two more disorders I want to talk about that antidepressants are approved for. Next is, and I have to look these up myself. So SC, that's smoking cessation. And so that's actually not really a mental health disorder per se, but nicotine dependence, it's a substance abuse or a substance use disorder. And bupropion in the branded product Zyban is actually approved for smoking cessation. And then there's pain, right? And so I already mentioned that milnacipran is approved for fibromyalgia. Well, duloxetine is approved for fibromyalgia, chronic musculoskeletal pain, neuropathic pain associated with diabetes. So those are the three for duloxetine. And so that kind of goes over what these medications are approved for. And what you'll notice is some of them are approved for multiple things, and there's several medications that are only approved for one thing, right? I mean, we've got citalopram's only approved for depression, vilazodone, vortioxetine, trazodone, nifazodone, mirtazapine, all only for depression. Fluvoxamine, fluvoxamine only for OCD, and we've got desvenlafaxine, levomirazepam, gepirone, also only approved for major depression. And so it's important to know this from a testing standpoint and from an insurance approval for medications for the treatments standpoint. And also, when you've got FDA approval, it does indicate that there is more evidence that like we've actually like done like expensive research and found that yes, this works better than placebo. And if we don't have the approval for another med, that doesn't it may not have been tested, or it may have been tested and found that it didn't work. And the thing is there's a lot of unpublished literature out there as well, which is unfortunate. So it may be that, you know, vilazodone was tested for GAD and they found it not to work and they didn't publish it because they didn't want an article out there that showed that their med wasn't as effective as something else, and so they just like bury it. You know, you don't have to publish everything you research, right? And so a lot of negative stuff is not published. And in that same vein, you may have done 10 studies testing a medication for depression, and only one of them was positive, and that's the one you published. And then, I mean, this is called publication bias, and so there's just, and then we don't even know this other data is out there. And so we've got this bias in that, okay, we finally, it worked this time, you know, it just happened by chance. And you know that's not great, because then people are going to be, you know, taking this med and prescribing this med for a condition that, you know, 9 times out of 10 didn't really work. And when we talk about gepirone, we're going to talk about the like decades long history that gepirone went through to try and get approval. Um, so that's an overview of all of our, you know, second generation antidepressants, or, you know, receptor selectives, and what they have FDA approval for. And then I also want to cover some off-label uses for them. Okay. And you know, you could probably get away with using almost any one of those medications off-label for almost any one of the conditions that I mentioned. So like those are things that you could think about, because we're all the similar mechanisms of action. Especially if you've got one SSRI doing something, you could use a different SSRI for it, right? And then there are some conditions that there are no medications that are approved for, and so like how do you treat it? Well, you've got to go off label, right, if you've got a condition like that. So I wanted to go through some of the most common um, conditions that these medications might be used off label for. So um, if you've got a serotonin reuptake inhibitor induced sexual dysfunction, and I'm going to have a whole lecture on like what that's about. But out of all the ones we mentioned, most of them can cause it. Some of them don't affect it at all. And one of them, bupropion, might actually make it better. You know, this is something I was taught, but you know, like I said, we're going to go into sexual dysfunction. I'm going to have a whole episode on that. But I've just, in my personal experience, not found bupropion to be that helpful for this. It's done a lot. And I might use bupropion to avoid having the sexual side effects, but actually treating it, maybe. I mean, it's done a lot. There might be the patient out there that it helps. It might help a little bit, but it is something that is done, and I can't say I haven't done it. Okay, but that we might go off label, because there is no approved treatment for a serotonin reuptake inhibitor induced sexual dysfunction. There is no approved treatment for that. So bupropion is one of the things we might use for that, and there's a couple others. And like I said, but out of the list that I just listed, that's the one. ADHD. So we have some approved treatments for ADHD. We often use bupropion. I don't like to, because it's not that effective. But if you, a lot of people are afraid to give patients the controlled substances that treat ADHD, or they're not quite sure if they have ADHD. They're not really convinced. The patient really thinks they have it and they want to get treated for it. And so often, like bupropion, and bupropion does work very similarly to the medications we do use for ADHD. It doesn't do even close to as good of a job. But We will sometimes use that, if we're not quite convinced of the disorder, or if we're worried about some of the side effects, or that someone might be like, they might abuse the controlled substance. So sometimes bupropion off label. I've even heard it's listed third on many algorithms as like what you should try if after they've failed some of the other treatments. And then there's some other pain disorders that duloxetine could be used off label. So chemotherapy induced peripheral neuropathy. So other pain disorders, especially like neuropathic pain, you could use duloxetine for, even if it's not, doesn't have that specific list, because there's not really anything that's listed for that. Stress urinary incontinence, duloxetine could be used off label. Migraine prevention, venlafaxine has been used for that off label. Although there's so many other meds you could use for that. You know, it- Oftentimes when you're going to go off label here, it might be like, well, I'm using the venlafaxine for their depression or anxiety or whatever, and they have migraines. Maybe I can kill two, three birds with one stone, right? So that might be a reason to do that. I certainly, if I was just treating migraine prevention, would never reach for venlafaxine. I would reach for one of the other medications that we'll probably have episodes on migraines in the future, and we'll talk about those. But tension headache prevention, mirtazapine. There's not really much that's approved for tension headaches specifically. So mirtazapine, I've never seen that done. I've never done it myself, but I've seen it in lists. So insomnia, the trazodone and mirtazapine, very frequently we use those two. The like trazodone is probably one of psychiatry's favorite first choice drugs to use for insomnia, because the medications that actually are FDA approved for insomnia, um, they're only really supposed to be used for short term. So these are like your benzodiazepines and your Z hypnotics, um, like Zolpidem and ecopoclone and Zaloplan, right? So we don't really like to use the meds that are approved for insomnia long term, because they tend to not work and cause dependence. And trazodone doesn't really do that. So that's why we like to use trazodone. Plus, it's an antidepressant, and if they're seeing me, they're probably not just coming for insomnia. They're probably coming because they have depression, anxiety, and so the trazodone may help with that in addition to their insomnia. And then mirtazapine, I see it used often. I'm very careful with mirtazapine because of the weight gain issue. But if I've got a patient that's underweight, or trying to maybe bulk up, get some muscles, not really, they don't put on weight too easily, I might go with mirtazapine. That would be a good choice for insomnia. Another one, binge eating disorder. There's I believe that Vyvanse is the only approved treatment for that. So I don't know how effective any of these antidepressants are at it, but when that's something that could be considered, that has been considered. Usually patients have depression and anxiety on top of that, and that would be the reason to use the antidepressants. You don't have like a pure binge eating disorder. I would probably, go with something else. Body dysmorphic disorder. This is a disorder where, what you see in the mirror is not what other people see when they look at you. Like, you see defects in yourself that aren't actually there. And so body dysmorphic disorder, it doesn't mean that you don't like the way you look, right? It means that you don't like the way you look so much so that you're seeing problems that, you think you're fat when you're actually underweight. You think you've got, these horrible huge moles that look disgusting when there's barely a tiny little dot there, maybe nothing, right? So these are disorders where people are depressed and anxious, so these medications, are could be used off label for. Premature ejaculation. So as we're going to go through this, these medications cause sexual side effects. So if you've got somebody who is, too easily going to ejaculation, they engage in sexual activity and it ends very abruptly. You could actually use the side effects of these medications, what we would call side effects, but they're really just effects. to treat that. And paroxetine and fluoxetine are used the most because they've been around the longest. They tend to cause that side effect the most, and so that's why they are used for that. And I've heard this. I don't know if this has changed, but premature ejaculation, I believe, is the most common sexual disorder. So it's much more likely that you're going to have premature ejaculation than you're going to have like the disorder that people take Viagra for, right? It's usually the opposite problem, but people are even more embarrassed to talk about that. I think the Viagra and all these other medications kind of normalize that, oh, it's normal for you to like have difficulty getting an erection. Go ask your doctor about it, buy our drugs, right? But, finishing too soon is still kind of like, oh, that's embarrassing. I don't want to talk about that. So then patients may not bring this up. But I've treated several patients for this, and I've given them, low doses of paroxetine or fluoxetine, and it's worked quite well for them, actually. I would actually say these medications, their effectiveness for treating what they're actually FDA approved for is not that great. It's barely better than placebo. For some patients, it's a lot better. We'll go into that in more detail, but they're pretty good at slowing down your kind of sexual reactions. So I would they're I would say they're actually better at treating premature ejaculation than at anything that they're approved for. So on this off-label use list, I would say that the insomnia one, the trazodone and mirtazapine are pretty good with insomnia, but the serotonergic medications are excellent treatments for premature ejaculation. If I have a patient with that, I'm excited because I know I'm going to be able to help this patient. But for what patients typically come in for, it's hard to treat. But this is one we can actually. Oh yeah, that's one I can actually do. So it's not something to be embarrassed about. It's something to be excited about because we can actually like do something with it. And the next one, personality disorders. All these medications are commonly given for personality disorders. Mood stabilizers are often given, antipsychotics are given, and there's just really no evidence that they are all that effective. And like it's often a sign to me that somebody has a personality disorder when they come to me on like 5 different medications. It's like, okay, we're treating like a million symptoms in the moment and frequent changes of meds, frequent changes of doctors. And is any of this really working? Typically, when you're giving medications for a personality disorder, you might be helping with a symptom, maybe an insomnia or something like that. But for the actual, like, the worst part of what you're suffering from there, uh, they can help, but it's more the fact that the patient's getting help that helps them, if that makes any sense. So it's the fact that, they've come to you and you said, okay, I'm going to treat you, I'm going to give you something. That they often get better quite soon just because they needed that. But then the effect of that wears off. And then it's like, oh, this isn't working. I need a higher dose, or I'm getting all these side effects now. And then you change it. And then every time you change, you'll tend to see that there's a positive reaction that doesn't last. And then you either end up changing things frequently, or even worse, you end up putting things on and then having to add things. Okay, well, because the patient's like, oh, I don't want to come off of this because it helped. And then, okay, well, now I'm putting something else on. And then they don't want to get rid of that one either. So then we're putting you have a lot of these patients that have personality disorders that they like taking medication. It does something for them, just the act of taking it. And the more pills I take, the more it means that I'm like getting fixed from this. But it's really not ideal. And, I'll probably at some point need to do an episode on personality disorders and go through all the medications and how there's just like not really great evidence that they work, and like, when to use them, when to peel them off, etc. And then the last off-label use, I kind of during COVID, the height of COVID, they actually found that fluvoxamine helped with inflammation associated with COVID. I don't know how it was studied. It was kind of seen because people were taking it, and then, oh, they're taking this for their OCD or whatever, and they have COVID, and they got a little better, or they didn't have as bad of a disease. And fluvoxamine has some function with the sigma 1 agonism, and none of the other antidepressants actually act on this sigma 1. And so it was studied a little bit, and they found, hey, maybe this helps a little bit. But I don't think there's any patients that were put on fluvoxamine for this. They got COVID, and then we gave them fluvoxamine. Um, I just don't think it was done. I think it's something that was kind of interesting, that was seen like, oh, it's got this different mechanism, and it seems to have some sort of effect. I don't know if it's enough effect to really, you know, advocate using it, but it could lead to research that like actually unveils something really interesting. So that takes us through the kind of preview of like all the second gens and what they're FDA approved for, what they're off label used for. And I wanted to actually add something on the end of this one. I'd said before that if I make changes to stuff we've already gone over, I will cover it in separate episodes. And since this wasn't a very long one, and this is just a quick update, I added a contraindication and caution section for the tricyclics, and I just wanted to kind of review that. So, when we talk about contraindications of medications, it's like, don't do this, right? Like, if you have the contraindication, it's like, don't give them the medication. And in the caution category, it's like, hey, we should be worried about this. You might want to consider not giving them this medication. Or, if it's indicated, just be aware that you need to look out for this. So, um, I wanted to go over those. So the contraindications to using a tricyclic, there's a lot of cardiac stuff, right? Remember how they can cause arrhythmias, they can overdose, they're very dangerous. So a lot of cardiac stuff we really don't want to mix with the tricyclic. So the person just had a heart attack. They have an arrhythmia. They've got an irregular heart rate. They've got uncompensated, or I have uncompensated on here, but I think it's decompensated heart failure. They have a pheochromocytoma, which causes huge spikes in blood pressure, but it's an extremely rare condition. Um, and then, or they have some sort of QT prolongation. They're taking a medication that prolongs QT. They have a history of it. And actually, our next episode, I'm going to go dive super deep into QT. So I'm not going to explain it here, but just uh, the tricyclics cause a QTC prolongation. So mixing them with others or patients that already have it, not a good idea to combine the tricyclics with that situation. And then cisapride is a medication that I believe was taken off the market. It's still listed as a contraindication for specifically amitriptyline. I'm not sure why it's only amitriptyline, but there's also a black box warning on cisapride. It's a GI motility medication, but it can cause arrhythmias. Okay. Some other contraindications. So the tricyclics are all processed through the liver by the uh, the P450 CYP2D6 enzyme. And so taking a 2D6 inhibiting medication with the tricyclics is not a good idea because it's going to increase their levels. And we really don't want to increase levels of tricyclics because it can cause overdose and death and so forth. So don't mix them with 2D6 inhibitors. Um, Also, if they, the, you don't just have to have a 2D6 inhibiting medication. You could be a poor metabolizer. You could have an enzyme that's a reduced function, right? And this is another reason why we don't like to use the tricyclics, because they do have that narrow therapeutic window, and so that's where taking too much can really cause a lot of problems. Lithium's another one. We've got to keep them in a narrow window. That's why we have the blood levels that we can grab for these. And if you grab the slides, which I will be updating frequently, I actually added the blood ranges for some of the other tricyclics that I didn't mention before, the ones that aren't commonly used. I found some blood levels for those as well. So that'll be on the new slides. And then another contraindication within 2 weeks of a MAOI. And then if they have a seizure disorder, because there's also seizure risk with these meds. So those are some of the contraindications. And then the things to be cautioned. All right. So if we talked a lot about anticholinergic risk. So if someone's anticholinergic sensitive, caution. Um, if they're on medications that cause slowing of the heart rate or bradycardia, caution with the tricyclics. If they have hypokalemia, hypomagnesemia, so that's low potassium or low magnesium, or if they're taking a medication that causes that, so that's a lot of diuretics, stimulant laxatives, amphotericin B, and glucocorticoids. So w- that having low potassium and low magnesium, that can prolong that QT. And like I said, we're going to get into that in the next episode, but we don't want to be prolonging the QT with a medication that also prolongs the QT because it can cause dangerous arrhythmias. Um, if their bone marrow is suppressed, I'm not sure why actually on that one, but it is listed as a caution. I couldn't really find that. If the patient has orthostatic hypotension, these medications cause that, so we don't want to make it worse. If the patient has cardiovascular disease, so I mentioned some of the conditions on the contraindications that we really don't use the TCAs with, but if they have any kind of cardiovascular disease, I'm still going to have caution with the TCAs. Diabetes, they can affect glucose levels. If they have hepatic or renal impairment, those are always things that we consider with any medications. If you've got impairment of your liver, that could make it harder for you to process the medications and get them out of your system. Same with renal impairment, and it can actually damage those organs if they have that impairment already. If the person has a history of mania, of course, we don't really want to be using depression medications. Um, Before surgery, remember I talked about using epinephrine uh, is contraindicated with these medications. So careful before surgery. And then if they have risk of seizures, so if they have seizure disorders, don't use the medications. If they have a risk of seizures, so they have head trauma, they have some central nervous system abnormalities, alcohol abuse. So that there's a risk that they could go into withdrawals or something like that, that they could get a seizure. That's not an absolute contraindication, but that's something to take caution of. So, you know, I know we talked a lot about the dangers of tricyclics, but I wanted to kind of spell out these are the things that we really don't want to do when we're taking a tricyclic, and these are the things that we really want to take caution of. So, hope you enjoyed this lecture. Um, that was a good overview of the antidepressants we're going to be talking about in the future. And the next few lectures, I'm going to go over some of the big adverse effects that you get with the serotonergic medications. And so we're going to have whole episodes on suicide risk, QT prolongation, sexual side effects. I think there was another one in there. And then we'll go over the rest of the adverse effects. Will be another lecture because there's several potential ones. And then we'll go through the individual serotonergic medications one by one. But I wanted to kind of give that I want to just do a big whole episode on the side effects so we can kind of dig deep into those. But, thanks for joining me. Hope you enjoyed it. Follow, like it, rate me, tell your friends. I'm trying to get the word out. I'm hope that you think this is great content and that you'd recommend it to other people, but I'll see you next time.